I'm Dr. Richard Penson, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Combos Are Complicated, Navigating the Balance of Efficacy and Safety in Advanced Endometrial Cancer. Today's program is supported by an educational grant from Merck and Eisai. Today's activity is brought to you by CME Outfitters, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an advanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us your feedback on the program and the platform as well. Again, I am Dr. Richard Penson, Associate Professor of Medicine at Harvard Medical School, and I'm also the Clinical Director of Medical Gynecologic Oncology at Massachusetts General Hospital and the Institutional Review Board Chair at the Dana-Farber Harvard Cancer Center in Boston, Massachusetts. Let me now introduce our faculty. Fabulous faculty. Joining us today is Nicoletta Colombo, Director of Gynecologic Oncology Program at the European Institute of Oncology, an Associate Professor of Obstetrics and Gynecology at the University of Milan Bicocca in Milano, Italy. Welcome, Nicoletta.
Hello, hi. Thank you for having me today. Thank you.
And Dr. Shannon Weston, Associate Professor and Director of Early Drug Development in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. Welcome.
Thank you so much. I'm so excited to be here.
Fabulous. So the learning objectives on today's activity are firstly to examine the rationale and data leading to the approval of combination regimens in advanced endometrial cancer. And secondly, to apply best practices to address treatment challenges related to combination therapy in advanced endometrial cancer. In the US this year, there will be almost 13,000 deaths from endometrial cancer. And unfortunately, Black women have the poorer survival outcome. You can see in the graph on the left, the red line representing Black women with a poorer survival. In the graph on the right of endometrial cancer, a worse type of tumor, the disparity is even greater. And if you look at this slide, a bar chart of the difference based on race and age, you can see in those 5 columns, the P53 mutation on the far left, now we use as an important triage tool in terms of adjuvant chemotherapy, wild type P10, and then the 3 clusters on the right are all measures of aneuploidy, genetic aberration. And you can see that in Black women, particularly in Black women over the age of 65, those green bars, they are a standout worst group in terms of having the adverse prognostic molecular alterations. Let me present a patient case. Our first case is pretty typical. She is a 63-year-old Black woman who presents with heavy vaginal bleeding with clots. She's found to have stage 3C1 endometrial adenocarcinoma, undergoes a hysterectomy, lysis of adhesions with bilateral sentinel lymph node biopsy, and has grade 2 out of 3 disease, positive pelvic lymph nodes, so disease metastatic to the lymph nodes. Shannon, what are your thoughts about our patient?
Well, I mean, I think this is what we see in clinic. This type of patient is who we see in clinic every day. And, you know, I'd be very interested to know how long she was having bleeding, because I think one of the issues that we see with Black women and women in general, but really specifically in our minority women, is they often are complaining of these issues for a long time before they get assessed appropriately, and that leads to higher stage at diagnosis. But regardless, here we are now with a patient with a 3C1 endometrial cancer. And I think really what we're going to start thinking about is what are we going to do from an adjuvant setting to help improve, hopefully at the very least, her progression-free survival, but also her overall survival. And so I really think that where we're going with that is looking at combination strategies.
Perfect. So Shannon, are there any studies that you need to be thinking about with respect to this patient?
Yeah, I think there's two major studies that that we can be looking at to help guide our decision making for this patient. The first is the PORTEC-3 trial, which was run out of Europe. And just as a refresher, this was a patient population that had not previously gotten treatment for their endometrial cancer and had high risk disease. And that was defined as either stage 1, grade 3 with deep invasion or LVSI, stage 2 to 3 all comers, or stage 1 to 3 serous or clear cell. So really trying to select out the group that has the worst overall prognosis and outcomes. And they were randomized, and this is important to pay attention to as we talk about this study and the next study. For this study, the control arm was pelvic radiotherapy, and the investigational arm was the combination of chemo with radiotherapy, and that included cisplatin as a sensitizing agent during radiotherapy, followed by 4 cycles of carboplatin and paclitaxel, and the primary outcomes were overall survival as well as failure-free survival. And what PORTEC-3 demonstrated to us is there was a clear improvement in both five-year failure-free survival as well as overall survival with that combination of chemo radiotherapy. And that was in all comers, but they also teased out and looked that it seemed to be especially in those patients that had node-positive disease, like our patient in this case. Now, I would be remiss from the States not to mention the other study that was done in this patient population, which is GOG 258. Now, GOG 258 was a very similar population of high risk stage 3 or 4A endometrial cancers, and they also included stage 1 or 2 serous or clear cell tumors. And now here's the difference between GOG 258 and PORTEC-3 in that the standard of care arm for this was chemotherapy, paclitaxel and carboplatin, as compared to the investigational arm, which was the chemo radiotherapy arm and looked very similar to the chemo radiotherapy arm that we saw in PORTEC-3. Primary outcome for this study was recurrence-free survival, though they also looked at overall survival and quality of life. And what they found was that the addition of radiotherapy to that backbone of chemotherapy did not improve relapse-free survival as compared to chemotherapy alone. So that puts us in a position of, well, what do we do? You know, it's hard to do cross-trial comparisons. And obviously when we're looking at this, we think, gosh, why couldn't we have a 3-arm study, right? That had the radiotherapy, chemotherapy, and chemoradiotherapy all together to really understand which is truly the best. But I think for the purposes of our patient here, the curves are very impressive for that PORTEC-3 trial, and I would consider chemoradiotherapy for her.
Fabulous. There's actually some really great questions in the chat.
Oh,
so somebody asks, what is the biggest reason for the disparity? And you absolutely identified access. And then we were talking about the molecular determinants of outcome. Do you have a sense about, with the injustice that we find so painful, whether there's a specific thing, maybe not just that impacts the poor outcomes for patients, but that we can do something about? What's your sense of that?
Well, gosh, this is a loaded question, and we could probably spend the rest of the webinar talking about it. But just in brief, I think we've often said that access to care is one of the biggest issues, and it certainly is. We've shown over and over again that getting in with a GYN oncologist, medical oncologist that specialize in GYN cancers provide the best outcomes. But it's more than that too. It's also supporting people in their community, making sure that they can get to their timely, stay on task and get their entire radiotherapy, supporting them from transportation, childcare, lost wages. Those types of things are huge impact for a population. In addition, there's provider bias, right? I kind of mentioned that, and what we've seen is, systemic racism and bias in the medical community and structures. We need better education for the medical trainees as they're moving up, so they listen and learn and understand the symptoms and get those patients evaluated in a timely fashion, so they're not presenting, they're not getting diagnosed at later stages when they could have been identified earlier when they first reported their symptoms.
Yeah, and somebody asked a really eloquent question. How has this changed with COVID? And I think there is evidence that COVID has, as a stressor on the system, has made these disparities even clearer, which is tragic. I think one of the challenges for the academic is we see these different, not quite overlapping studies, and we don't necessarily send a clear message. And so this sort of educational opportunity is great. Node positivity, especially in high-risk disease, is the biggest marker for risk of systemic recurrence metastasis. And that's when chemotherapy really plays its role. And working to make sure all of the patients who might benefit get that is important. So let's assume our patient receives chemoradiation therapy, but the cancer recurs. What then? Nicoletta, what would you recommend?
I think for this patient, I might consider initiating her on immune checkpoint inhibitor agent. And this is because an important point here is that the patient has a mismatch repair deficient tumor. And we know for these patients, single agent immune checkpoint inhibitors showed a very high level of efficacy. In this table, you can see summarized the main results from the most important trials. And as you can see from Keynote 158, pembrolizumab demonstrated 57% response rate in patients with deficient mismatch repaired endometrial cancers. Also, dostarlimab was tested in a very big trial with more than 100 patients with endometrial cancer. And here the response rate was 45% for patients with deficient mismatch repair tumor. And similarly, durvalumab had a 47% response rate in deficient mismatch repair tumor. So I think there are no doubts that single agent CPIs work very, very well in this population.
Mm. These agents sort of that really got established in tumor agnostic studies from Johns Hopkins. It's a major breakthrough to have a biomarker that really identifies patients who have extraordinarily fabulous and durable responses. I think this is really a game changer in terms of our armamentarium. So let's stop for a moment and ask our audience a question. CPIs are finding widespread use in many tumors, including endometrial cancer. We're now moving on to trying combination therapy with these agents. What's the rationale for combining CPIs and VEGF inhibitors for the treatment of endometrial cancer? There are 5 options. Please indicate your answer. CPIs downregulate VEGF expression and reduce tumor angiogenesis, number 1. Number 2, CPIs relieve tumor-mediated immune suppression and allow recognition of cancer neoantigens. Number 3, VEGF contributes to immune suppression and VEGF inhibitors may augment the activity of CPIs. Number 4, VEGF and CPIs stimulate immune cell proliferation through shared intracellular signaling pathways. And number 5, I'm not sure. So go ahead and vote now. Oh, that's interesting. So the correct answer, highlighted in yellow, is that VEGF contributes to immune suppression in the microenvironment, and VEGF inhibitors may augment the activity of CPIs. Nearly half the people were not sure. So thank you for your honesty, and that's where we want to start. Okay, let's start with questions and get really clear answers to this. So what if the patient did not have a microsatellite unstable high or a deficient mismatch repair tumor? So in our next case, this is a patient of mine, this is not her real name, a 72-year-old white woman She originally had stage 1A microsatellite stable, grade 1 endometrial cancer. Thought she's cured, so did we, but at 4 years, she presented with lung metastasis. You can see in the CT scan to the right, lung met in the right lower lobe. But there were also peritoneal and nodal metastases, small volume, almost asymptomatic. She had a cough and a scan to find that metastasis. She was treated over a number of years with the combination of tamoxifen, megestrol acetate, and then the aromatase inhibitor, letrozole. We genotyped her tumor from the lung biopsy, and she had mutations in PTEN, CTNB1, ESR1, ARID1A, and PI3 kinase. Her tumor mutational burden was 9. Our lab cutoff is 15. Nicoletta, what would you recommend for this patient?
Well, in this particular case, we know that single agent CPIs are not very effective in the absence of MSI high or mismatch repair deficiency. So I think one important strategy is to utilize combinations. And we know that vascular endothelial growth factor, VEGF, create an immunosuppressive microenvironment. And this is done by inducing abnormal tumor vasculature that reduces T-cell trafficking and infiltration. Also, VEGF stimulates immunosuppressive regulatory T-cells and inhibits dendritic cells cell function, driving them into an immature state. And finally, inhibits T-cell function by binding to VEGFR2 on T-cells. So I think for this reason, it makes absolutely sense to combine an anti-VEGF agent with an anti-PD-1 drug. We know that lenvatinib is a small molecule tyrosine kinase inhibitor, which targets VEGFR 1, 2, and 3, but also FGFR 1 to 4, RET, c-KIT, and also PDGFR alpha. So on the other hand, we know that pembrolizumab is effective and has efficacy, particularly in patients with endometrial cancer that are MSI high. But the inhibition of VEGF-mediated immune suppression by lenvatinib may lead to an increased activity of pembrolizumab. And this is why these two drugs were combined in now several clinical trials. So let's see what are the clinical data. And from the clinical point of view, we have important results. First of all, in the Keynote 146, the combination of lenvatinib and pembrolizumab showed overall response rate at 24 weeks of 38%. And also the duration of response was 21 months. And the median progression-free survival was 7.5 months, and the median OS 17 months. And particularly in patients with MSI high tumors, overall response rate was 64%, but also in the MSS tumors was 36%. There are also other combinations which have been tested, such as the combination of nivolumab and cabozantinib. And this combination showed activity with 25% overall response rates. And we don't have yet results from the combination of atezolizumab plus bevacizumab, which was tested also in a phase 2 study.
Mm. Somebody from the chat actually asks a bit of a tough question, but a great question. And either you, Nicoletta, or Shannon may sort of want to comment on this. Can you substitute bevacizumab for lenvatinib or other CPIs for pembrolizumab? Nicoletta, you obviously have a European perspective, and maybe we'll get Shannon to follow up with an American perspective on that.
Yeah, I think theoretically you could, but actually we don't have solid data as yet, even though, as I mentioned here, there is this phase 2 study looking at the combination of atezo and bevacizumab, and this is exactly what they asked for. I mean, it's a different actually, this is an anti-PD-L1 instead of PD-1 plus bevacizumab instead of tyrosine kinase drug. So I think we should wait for this data just to demonstrate that you can achieve exactly the same results. But the results with the combination of lenvatinib and pembro were so striking and so good that, of course, we need solid data in order to substitute this kind of combination.
Right. And the off-target, the sort of dirty TKI effects and how much that may be different, and maybe specifically VEGF3, some of these sort of other things may mean that it's different, but bevacizumab is a well-tolerated and very popular agent. So Shannon, what's your take on that? With a really well-informed patient comes to you with a stack of internet information and sort of presents you with a plea, what do you say?
Yeah, I mean, I think you just nailed it. I guess we don't really know. Is it all this synergy really driven by just the VEGF, or if there's more to some of those other targets that lenvatinib is hitting? And so that's the question mark. And I am a little bit kind of the cabozantinib data kind of give me a little bit of pause, right? Because it didn't seem quite as profound. And I know cross-trial comparison, don't ever do it, but we do it all the time. But it does make you wonder, not all these drugs are necessarily created equal as far as what they hit, and if that'll be reflective in kind of the impact that we have. So I do hold pause with that and really do stick right now to the lenvatinib combination, because I feel like that's where our data are the strongest.
The dean of the medical school a few years ago encouraged everybody to think out loud, which is not typically something you do at Harvard, I have to say. Most people are pretty cagey about putting their cards on the table till they're sure. Like we expect patients to volunteer for clinical trials, so we do have the definitive answers. When I came to MGH nearly 25 years ago, 80% of the prescribing was off-label, and oncologists were really very creative. And on-label prescribing doesn't just save money, it definitely is a way that we deliver the best care to everybody. And we are a 90% on-label institution now. And for multiple reasons, that is a good way to practice and to think about what are options before necessarily listing those for a patient. Nicoletta, you recently presented further data on the Keynote 775 study at this year's ESMO. Can you take us through the overall data and the subgroup analysis?
Oh, yes. This is a great study, I think. Keynote 775, as you know, was a prospective randomized phase 3 study in patients with advanced endometrial cancer and one or more prior platinum-based chemotherapy. And these patients were randomized to receive the combination of pembrolizumab and lenvatinib or the investigator choice of doxorubicin or paclitaxel. And there were two co-primary endpoints, both overall survival and progression-free survival. And of course, there were secondary outcomes such as response rate and quality of life and safety. So this trial clearly demonstrated a significant improvement in progression-free survival in patients with proficient mismatch repair tumor, but also in the all-comer population. And as you can see, the hazard ratio was 0.60 and 0.56 respectively, with a p-value which was really very highly significant. Also, as you can see in the forest plot, the results were very consistent across all protocol pre-specified subgroups. Even more important is that the fact that the combination of pembrolizumab and lenvatinib provided a statistically significant improvement in overall survival, both in the proficient mismatch repair and all-comer population. And here the hazard ratio for overall survival was 0.68 in the proficient group and 0.62 in the all-comer population, with a median overall survival improvement of 5 and 7 months, respectively. Also, the forest plot indicated that the improvement in overall survival was consistent across all the pre-specified subgroups. And this is very important because the effect was seen and was consistent across all different subgroups. Now, recently, we performed also a post-hoc subgroup analysis, and we looked at the effect of this combination in patients with different histologies. I want to emphasize that this is just a post-hoc analysis, but I think the results are quite interesting because, as you can see, lenvatinib plus pembro improved progression-free survival in patients with endometrioid, serous, and also clear cell histologies. And this is true in the all-comer population that you see here in the slides, but also in the proficient mismatch repair population. Now, also we look at the different subgroups analysis. As you can see here in the forest plot, lenvatinib plus pembrolizumab improved progression-free survival across previous treatment regimens, namely one prior line only or more than one prior line, also receive neoadjuvant treatment or not receiving a neoadjuvant therapy, and in patients with either less than or greater than 6 months of platinum-free interval. Now, the improved overall survival was also observed in patients treated with lenvatinib and pembrolizumab versus treatment of physician choice across all histologies in patients with proficient mismatch repair status and in the all-comer population, what you see here in the slides. So, despite the small number of patients in the subgroup with clear cell histology, I think it is quite impressive to see the great improvement in overall survival in this population that, as you know, is a very difficult to treat population usually. We also look at the overall survival across other subgroup analysis, and you see an improved overall survival was observed across nearly all subgroups of prior therapy, except patients with more than one prior line of platinum therapy, suggesting that probably you have to use this combination quite early during the course of the disease. And lenvatinib plus pembrolizumab also improved overall survival in patients with a platinum-free interval of greater than or less than 6 months. Now, if we look at the response rate, you see that the combination of pembrolizumab and lenvatinib provided basically a doubling of overall response rate, with 30% compared to 15% in the control arm. And this is quite consistent with the response rate that we have seen in previous trials in the same population for the control arm. And also the duration of responses were much longer in the pembrolizumab lenvatinib arm compared to the control.
So thank you. As a result of these data, this combination is now approved for select patients with advanced endometrial cancer that is not microsatellite unstable high or with deficient mismatch repair, the microsatellite stable tumors who have disease progression following prior systemic therapy in any setting and who are not candidates for curative surgery or radiation. Nicoletta, you actually commented on a couple of things that I thought were really interesting about moving immunotherapy up earlier in terms of therapy. Is that your practice?
Well, unfortunately not, because in Europe, you know, we don't have the freedom to use this drug yet. Unfortunately, single agent was just recently approved, dostarlimab, in the treatment of MSI high population, and we cannot use yet the combination of pembrolizumab and lenvatinib. So my patients were only treated inside the protocol. But of course, I hope this will come very soon. And that would become a very, very important options for our patients. As you know, there is also a frontline trial with the same combination. And this is the LEAP-01 trial, and it's comparing this combination with the standard of care carboplatin and paclitaxel in the frontline setting of advanced and recurrent endometrial cancer. So I think this will be a very important trial to demonstrate whether it should be better to use these upfront, even before chemotherapy. Yeah.
Right. So we have clinical trials, for example, of combination axitinib avelumab in patients with prior systemic therapy. So we are quite keen to get people into that sort of thing before paclitaxel, carboplatin. I think the study that really drove it home to me was in melanoma in patients with BRAF mutations. The sequencing, do you do the targeted oral therapy first, targeting BRAF, and immunotherapy second, or immunotherapy first in those patients, and immunotherapy clearly won. So the shift to earlier is happening more and more, but you're right, practice should be driven by evidence base. And then the second thing you said I thought was really interesting is about the fact that this group of patients had both proficient and deficient, that microsatellite unstable and microsatellite stable tumors. Do you have clinical pearls about when you use lenvatinib with pembrolizumab in a patient with an MSI high tumor?
This is the hottest question, I think, because of course we don't have any direct comparison of the single agent versus the combination. And once again, I think we have to stick, to evidence-based medicine. But of course, these drugs are very effective even as a single agent. And we will discuss later the toxicity of the combination, which is not trivial, of course. And therefore, one consideration may be in a population like, the endometrial cancer population. Very often they are old and they have a lot of comorbidity. They are frail. And one may consider to use single agent CPI first instead of the combination, since the results were so good even with single agent. But of course, we saw, and we are not presenting here the recent at the IGCS. It was presented also the results about this combination in the Keynote 775 in the population with deficient mismatch repair. And of course, the improvement in progression-free survival and overall survival were very, very impressive compared to standard of care.
Yeah.
But once again, we don't have a direct comparison of the combination versus single agent, so I don't think we can draw any definitive conclusion.
Yeah, I tend to use the sort of experience again from melanoma. So in melanoma, the patients who had extraordinary responses to immunotherapy were the group with skin metastasis, nodal metastasis, and pulmonary metastasis. And my experience has been that those patients, maybe not with skin metastasis, but with endometrial cancer, with nodal and pulmonary mets, they can do really well. So the like our earlier patient with low-grade endometrioid tumor with an ARID1A mutation, you might do chemo and then consolidate with hormonal therapy and get a decade out of benefit, but that patient may do amazingly well with immunotherapy. Shannon, there's actually a great question in the chat. Maybe you could comment on, after commenting about like your American perspective, if single agent CPI fails, does that imply a lack of efficacy with a combo? So how do you bring it earlier, or are you bringing it earlier? And do you add lenvatinib when somebody progresses on?
This is a great question. And I think it's it should be done in a trial, because this is what we always wonder, right? Is with any agent, if you get a failure of a single agent to yield a benefit, or if a patient has had benefit and then subsequently there's development of resistance, can you resensitize that tumor by utilizing an agent that we think does result in synergy? So I think it's a great question. I hope we're going to get an answer from a trial soon, because I do think it makes sense. We haven't used it earlier. We've been very much sticking to the label. I think that, our institution certainly is strict in a good way. And what you were talking about using that on-label use, the 90% on-label use, I wonder where our institution is, but I think it's probably close to that, because, we do kind of stick right in line with with where we have an indication. So I've not used the combination of lenvatinib and pembrolizumab before chemo as a frontline as yet, although I'm very eager to see the LEAP-001 data be presented so we can see if this is something that's appropriate. And I would say I agree with Nicoletta that, you know, it's not only about benefit and it's not only about response, it's also going to be about adverse events, and it's going to be about quality of life and making sure that, you know, that quality of life is improved. And I think one thing we haven't really talked about is the length of time that the treatment occurs, right? So with chemotherapy, generally we're doing maybe about 6 cycles, maybe continuing it past then, but that certainly varies. But, you know, with the combination, we're looking at a 2-year time commitment of treatment. And that also matters to patients too. So it's something just to consider.
Right, commitment. So this regimen, the lenvatinib pembrolizumab, is the latest addition to our potential therapies. We're going to list here the NCCN guidelines, and you can see with the red box around the biomarker-directed systemic therapy for second-line therapy, and now a preferred regimen, lenvatinib pembrolizumab for the microsatellite stable tumors, the non-MSI high deficient mismatch repair tumors, and pembrolizumab as a single agent for TMB high, microsatellite high, or deficient mismatch repair. And then this other group, nivolumab, dostarlimab, larotrectinib, avelumab, cabozantinib, a growing number of targeted agents, which are other options, but very exciting change in the standard of care in terms of new preferred agents for therapy. So a polling question. Before we move to our discussion of adverse events and side effects, and really focus on what Shannon's saying about quality of life with this combination and how to manage them, how to get patients really well looked after, let's ask you, the audience, another question. Which of the following was the most common adverse event of any grade in the pembrolizumab lenvatinib arm of the Keynote 775 trial? A, fatigue. B, hypertension. C, proteinuria. D, stomatitis. And E, I'm not sure. So go ahead and vote now. Okay, so more people choose fatigue. I have to say, I'd be one of those people who'd sort of say fatigue and itch and some of these subtle things that we don't necessarily record so well in clinical trials. But in terms of documentation of toxicities, adverse events, any grade, the yellow, the hypertension, is actually the one that was most. Shannon, comments about hypertension as a common side effect?
Yeah, I mean, I think that it's clear that we see hypertension. And in fact, you know, when we're talking about managing these patients, we'll often send them home with blood pressure cuffs and be really proactive about expecting it. But I think you're right. I think it's easier to identify this, just like it's easier to identify bone marrow toxicity and things like that, because it's very well documented. It's a clear objective test. Whereas things like fatigue, which I do agree are a critical adverse event for this combination, may not be always obtained in the most thorough manner, let's say. And that's not meant as a judgment, because we all run trials and we all participate in these things. Yeah. And it's on all of us. But I do think that may be one of the drivers of why the hypertension was reported, you know, so much higher than some of the other things I think we see day to day in the clinic when we're treating these patients.
Right. So getting back to our second case, our patient received pembrolizumab and lenvatinib. She begins to experience nausea, fatigue, constipation, cough, and cold. She complains of being cold all the time. Shannon, obviously she is experiencing some adverse effects of therapy. Could you walk us through the instance of adverse events that are typically encountered with pembrolizumab and lenvatinib combination therapy?
Absolutely. You know, I think the first important piece is, before we get kind of into the nitty gritty of the specific adverse events, is to understand the impact, right? So what we know in this trial is that 99% almost 100, nearly 100% of patients had some treatment emergent or treatment related adverse event. And a large proportion of those, almost 89%, were more or greater than grade 3 or more, so significant adverse events. But the question is, how does that impact their therapy? Because sometimes we can have a grade 3 adverse event that doesn't, negatively impact the patient's quality of life, and we may continue them on the same level. So from the standpoint of dose reductions, we saw that in about 66% of patients. Dose interruptions, again, in about 70% of patients. But most importantly, could they stay on therapy? Were we able to find that kind of sweet spot dose that we're looking for and keep that patient on this therapy that can potentially extend her life? And what we saw is about 33% of patients had a treatment emergent adverse event that led to discontinuation, including 30% of the lenvatinib alone, 18% of the pembro alone, and then 14% of the combination. So when we look kind of more in more granular detail about which adverse events may have been driving that, you can see that, again, those top events that were graded not only as any grade, but then really getting specifically into that grade 3 or more were hypertension, hypothyroidism, which is an immune-related event, and then diarrhea. And diarrhea, of course, can be a struggle, right? Because we know that can be related to the lenvatinib, or that can be related to the immune checkpoint inhibitors. So I do think that one can be a troublesome one as we're trying to tease out where the etiology is and determine which agent might need to be held or in the case of lenvatinib, dose reduced. In addition to those kind of major or most common adverse events experienced by the patients, we also saw things like nausea, decreased appetite and vomiting, constipation, like our patient today, and then of course fatigue, which is a huge impact. Now, I love this graph. I think this is super helpful to us about really understanding when to expect these adverse events, because really when you're dealing with this and you're trying to get your patient an effective therapy, expectations are key, and being able to tell your patients, one, which side effects to expect, but also to understand the timeline and how common that is. I think that really helps kind of level set and get your patient on in the best possible place to be able to tolerate this regimen and stay on this regimen so she can get the best benefit. And what we saw is that really from the standpoint of hypertension and fatigue, those tended to be fairly early onset, really within just starting therapy. And then you can see as time progresses, you see more of the musculoskeletal pain, stomatitis, nausea, decreased appetite, and proteinuria. And interestingly, it gets better over time. So as we find that sweet spot, as we make those dose interruptions, make those dose reductions, we can reduce the incidence of these adverse events and help your patient have much better quality of life as she progresses on therapy. I would also note just a few other kind of key adverse events and really where we expect them to come. You can see there that around the second to third cycle, you're seeing more of the vomiting, diarrhea, development of that hypothyroidism, as well as weight decrease. And then of course, the palmar-plantar erythrodysesthesia, where you get that hand-foot syndrome that can be so irritating, but luckily can really, we can work with dose reductions and some symptomatic measures to help address that.
Actually, Vicky Macker was the person who put me onto this. We quite often will use Alanzapine Zyprexa for weight loss. It's a notable contribution from the lenvatinib. The diarrhea is really interesting. So remember, in this study, more than 50% all grade diarrhea, 7 or 8%. I think it was one of the two in the phase 2, the other in the phase 3 with grade 3 or greater toxicities. But the lenvatinib single agent study that we did, that was a 31% all grades diarrhea and 4% grade 3 toxicity. So it contributes significantly and earlier. So I agree with you. I love this thing. At 8 months, that's the time when colitis is really kicking in, 2 to 3 months into treatment. And so the things like a bloody diarrhea, more than 7 stools a day, grade 3 diarrhea, a constellation of other immune things like developing hypothyroidism makes you think that it might be colitis, and having a low threshold for getting a biopsy. Nicoletta, do you have a particular practice when it comes to intervening for diarrhea?
No, as you said, I think it's very important to discriminate the diarrhea attributable to lenvatinib to the colitis. Of course, that's I think is the most tricky thing, because as you know, there are some side effects which are really common, can be attributed to both lenvatinib and also to pembrolizumab. And of course, it's important to recognize when it is immune-related side effects, because in this case, you may need a more aggressive approach, including corticosteroids, and of course, referring to GI specialists, and also hospitalization sometimes. So I think it's really crucial to understand, as you said, when it's very frequent, when it is severe, when you have this very watery or bloody diarrhea, then it's time to be a little bit worried and to take the proper action to deal with that. Yes.
Yeah. And to involve your colleagues. I love the fact that we can ring up GI and get a quick flex sig and maybe topical treatment, early colitis with steroid enemas, so that they don't mitigate against the benefit from the immunotherapy with systemic steroids. So early in proactive intervention, having a team, having a nurse practitioner who will call the patient at weekly intervals and check in. Shannon, you're a team believer?
Oh, for sure. I mean, we make sure when we started rolling this agent out, we had our nurses get counseled. We had our nurse practitioners and PAs, our pharmacists. Everybody is working together, because our goal is to be able to give these agents to the patient. And there's nothing worse than a patient having a grade 3 or 4 toxicity and walking away from a strategy that may have helped her live longer. That is what we don't want to happen. And so, yes, we're very proactive. We do weekly calls when they first start. We send them home with, prophylactic nausea medicines in case they need it. We send them home with prophylactic antihypertensives, like a script to have at the ready. We don't tell them to take it right away, but the minute they start seeing that blood pressure go up, they've got their drugs and they're ready to go. So we really do try to get out in front of whatever we can. And I agree, we are big time consulters. We have a multidisciplinary team that, obviously immune oncology agents are getting used across all different cancer types. And so we're very fortunate to have the opportunity to work with our endocrinologists and our dermatologists and our colorectal or GI specialists. And so we get them involved early and often. We jokingly say, we've got to spread that pain. We want to make sure that we're going to get that patient expertise from every potential opportunity, so that we don't miss a strategy that might help her.
Yeah, there are very few gastroenterologists who don't like scoping people. So foster friendships where you say, okay, is there any chance you could do a scope for us? And there's quite a few questions in the chat about this. Okay. Do you refer to gastroenterology immediately, or do you monitor for a while? And so the earlier in the clinical course, you might monitor for a while, but it's always horrible when you get it wrong. So twice I've really felt like it was the lenvatinib induced things, and I really felt like it was late that I got a gastroenterologist involved, and I felt terrible about it. Our worst ever one was actually wasn't lenvatinib, it was sodironib, but I admitted a patient of mine who was hypothermic and cold, slow and constipated with hypothyroidism from a similar tyrosine kinase inhibitor. So do not leave it too late. Be proactive. Don't feel bad if you do extra studies where somebody has got diarrhea and it's not yet colitis. Let's move on. That was fabulous. The management of side effects we'll probably come back to if we have time at the end, because we really haven't touched too much on what dose of thyroxine do you start on, what antihypertensive, and we'll hopefully come back to that. But I think the management of diarrhea is one of the things that people have most concern about. So let's go back to our second case. TSH is elevated at 8.4, free T4 low at 1.1. How would you manage this patient? What supportive care does she need? Does she need dose modifications? Nicoletta, what's your approach?
Yes, hypothyroidism actually was the most frequent immune-related adverse event observed in Keynote 775. But we have to remember that lenvatinib also may cause hypothyroidism. So once again, this is a kind of overlapping toxicity. For this side effect, no interruption is needed, but this can be managed with thyroid supplementation usually. Of course, there are other immune-related adverse events, more severe, and they are rash, pruritus, pneumonitis, diarrhea, and colitis, and hepatitis, and so on, and particularly endocrine disorders. Hypothyroidism is the most frequent, but also you can have adrenal insufficiency or diabetes. But these were really rarely seen in this trial. So generally, immune checkpoint inhibitors can be continued for grade 1, interrupted usually for grade 2 and 3, and permanently discontinued for grade 4. In the most severe cases, medications such as corticosteroids and immunomodulators can also be used. And as I said, it's very important to refer the patients to the specialist if you have any doubts. But I think overall, and you mentioned already, patient education, I think is really critical, and especially at the treatment onset. So in other words, I think patients should be educated regarding the known adverse events associated with this combination, and should be encouraged to communicate, and particularly during the initial weeks of treatment, they have to communicate when adverse reactions are most likely to first occur. Now, dosing modifications, including dose interaction for lenvatinib and pembrolizumab, and dose reduction for lenvatinib, were important management strategies for adverse reactions in this trial. For most of the key adverse reactions, the recommendation is to withhold lenvatinib treatment for persistent or intolerable grade 2 or grade 3 severity. And upon resolution to grade 1 or less than 1 or baseline, lenvatinib can be resumed at a lower dose. So you have to reduce the dose. So you first stop for grade 2 and 3, and when you have a resolution to grade 1 or less, then you can resume at a lower dose. Pembrolizumab dose was not reduced. Either you stop or you continue at the same dose. Only lenvatinib can be dose reduced, and you typically go from 20 to 14 and to 10 and then to 8. These are the levels of reduction that you can use. And of course, besides those modification and interruption, as we mentioned, optimal medical management should be also utilized when available, for instance, for nausea, vomiting, hypertension, diarrhea, and hypothyroidism. And so lenvatinib and or pembrolizumab dose interruption or lenvatinib dose reduction should be initiated. As you can see, there are several medications which were used during the trial. Of course, you do have side effects for which very effective medications are available. And first of all, you have hypertension. You see that about 50% of patients experiences hypertension were indeed treated with several different antihypertensive agents. And that's very important to be started very soon, as you mentioned early. So I think prevention is very important also for hypertension, because probably all patients should receive a cardiologist evaluation at the beginning, even before starting, just to identify this kind of borderline hypertension which can be there. and should be treated to avoid more severe progression to grade 3 and higher. So it's very important to recognize, and a very careful cardiologist evaluation should be important to be performed before starting the treatment, and to treat hypertension as soon as possible to avoid the progression to grade 3 and so on. I think also nutritional counseling is very important. Patients should be instructed to eat regularly and healthy food, and also to do exercise regularly, I think is very important. So for other side effects such as hypothyroidism, we already mentioned that you should use, of course, the appropriate treatment. Of course, you can use paracetamol for the pain, for the musculoskeletal pain. And so, as I said, overall, it is extremely important to recognize promptly these side effects. So I think education of the patient, prevention, and personalization is extremely important. Patients should be educated to report immediately, because these are old patients. So sometimes that, they tend not to say what they feel. So it's very important to tell them, to communicate with the nurses, with the physician, in order to be able to start the appropriate treatment as soon as possible.
Fabulous. So the that hypothyroidism, I think that some people start at 50. Some people will give 100 micrograms daily, just assuming that they are deficient. One of the things about these TKIs is that they reduce the blood flow through the thyroid, and part of the hypothyroidism isn't an immune inflammation in the thyroid gland, but it's actually the lack of access of the thyroid hormone into the bloodstream. So it can be quite early and quite significant. I had a patient recently who had they were on single agent pembrolizumab actually, but they had a tender, distended lower neck, and they had a thrill. Maybe I lied and thought I'd heard a bruit when I was a medical student, but this person had a thrill, not just a bruit. And so in complete panic, I talked to the endocrinologist, and she had acute sort of Hashimoto's, and my panic was met with sort of calm confidence, and we treated through, because this person actually had a rare tumor with a PD-L1 score of over 90%, and we thought we could cure her with the pembrolizumab. So, but the endocrinologist had a very different perspective. Cardiac toxicity, you might call up your cardiologist, he might panic. It's like, man alive, there's a 30% mortality for that. Can we just go up one slide? I wonder, Shannon, if I can just ask you to comment. This is a really helpful list of meds. So this is the data from the trial of the most commonly used antihypertensives. Do you have a system in which you start with one, add another, then call a cardiologist, or do you get cardiologists involved straight away? Do you have a practice pattern?
Yeah, I mean, I think what we do is we send them home with, and amlodipine is my drug of choice. We send them home with a basic script in a patient that has never had any hypertensive issues in the past. And that way we're kind of ready. If the blood pressure starts elevating, we can add that drug in and then monitor and see how the response to therapy is. I will say, for a patient that is on one drug and starting to have an elevation, or at baseline was already on multiple antihypertensives, that's when we get our cardiologist involved kind of right away. And we want to, and I think Nicoletta said this as well, we want to maximize control of that blood pressure early on and even before we start, and make sure she's kind of on all of the best medications she possibly can be on when we start, and that way we hopefully won't get into trouble once she's on the agents.
Yeah. So somebody asked in the chat, what blood pressure do you start meds? Do you have a threshold?
We are, 150 to 160 over 90. We're pretty tight, especially in a patient that was previously normotensive.
Most trials are 150/90, some are 140/90. So you're right. I think in some ways they're tightening up. Mechanistically, the calcium antagonists, amlodipine is our favorite too. They have a local effect in the wall, and nitric oxide may be the driver for these TKIs. So they're a great first choice. Our first choice is losartan, and we have some local MGH data in ovary and pancreas that the ARBs and maybe the ACE inhibitors alter the microenvironment and may be beneficial. There's a super cool trial in renal cancer in which they randomized patients to escalating doses of axitinib to drive effect, benefit, and used hypertension as the measure of your pharmacodynamic effect from your drug. And the patients on a higher dose actually did do better with PFS. So my bias isn't to start it too fast, but you definitely don't want to get out of control. So let's move the discussion back to what we started on earlier in terms of the access and underserved patients. So Shannon and Nicoletta, if you could both comment, what do you think is coming with ongoing trials, and what are our hopes for the future for those patients who do not respond like our patient?
Well, I think I will leave to Shannon to talk about new combinations. What I can say is that we have to remember that there are 3 trials ongoing now in the frontline setting. And all 3 trials actually combine carboplatin and paclitaxel with anti-PD-1 or anti-PD-L1. So one trial is the ATTEND trial, which is adding atezolizumab to carboplatin paclitaxel. The other trial is the RUBY, adding dostarlimab to carboplatin and paclitaxel. And finally, the NRG-GI 018, which is using pembrolizumab and adding pembrolizumab to chemotherapy. So I think these are very important trials because they may change the standard of care of frontline, because these are all in patients not previously treated with any treatment. And as we mentioned earlier, the LEAP-001 also may even lead us to use a non-chemotherapy regimen as a frontline treatment for these patients with advanced and recurrent endometrial cancer. So I think this is what, I mean, the ATTEND, I am the PI of the ATTEND trial, and we are very, very close. At the end of the month, we will be closing the accrual. So finally, we made it. The RUBY trial already completed the accrual, and the NRG, I think, is still ongoing. But I think, well, next year, at the end of next year or so, we will have some data. So I think this will possibly, again, change our frontline treatment. So that's what I see as the most exciting new possibilities for our patients in the near future.
Yeah. So Nicoletta has summarized these great trials that are going to be sort of definitive standard of care determining trials. But Shannon, you, as a drug development queen, do you have a sense for some of the new endeavors?
Yeah, I would add just one more trial to that list, which is the trial that I'm the PI of, which is DUO-E, which combines dostarlimab with chemo, but leads very much into the question that you were just saying, Richard, where, if we can add immunotherapy, is there an opportunity to even go one further? So DUO-E is actually taking that step further, and instead of just using a immune oncology agent as a maintenance strategy, we're also adding a PARP inhibitor, because the question is especially for that population that doesn't have microsatellite instability, can we maximize benefit and can we extend progression-free survival for those combinations? And so we're really excited about the opportunity for PARP and checkpoint inhibition to have that kind of impact in endometrial cancer. In addition, there's a number of really exciting combinations with both PD-1 and L1 inhibitors, crossing all sorts of different pathways that make sense for endometrial cancer, including anti-angiogenics like bevacizumab, AKT inhibitors like apatosertib, different PARP inhibitors, such as talazoparib, olaparib, as well as cytotoxic chemotherapy. So there's a lot of different agents that are kind of being explored to see if we can get that synthetic lethality and get the improvement in response and improvement in progression-free survival for our patients.
When we think about sort of lumpers and splitters, and I think, in many diseases, we are splitting up the traditional histologic subtypes into molecularly defined subgroups where we say, wow, you've got a really eloquent biomarkers telling us this patient needs this therapy. But in almost contrast to that, the lenvatinib pembrolizumab experience really has opened up the opportunity for patients to have access to effective immunotherapy by changing the tumor microenvironment. In your philosophy, Shannon, are you sort of rooting for our disadvantaged Black woman that she gets access to everything, or do you think the field moves on best for everybody in the end when we get these biomarkers that are really define the best outcomes for new drugs? Where are you at with that?
Well, I mean, I think what I'd love to see is more precision medicine where we're not necessarily lumping and we're taking the data that we have about our patient and what her tumor looks like and utilizing that to direct her care. With that being said, you nailed it. I mean, do we have access to that testing in every, across every city, across every country? Are we going to have that ability in a cost conscious manner to be able to get that type of testing for every patient? At this point, it can be awfully expensive. Although I think what's been great about the immune checkpoint inhibitors is that we've been able to use something that's fairly cost effective with immunohistochemistry. It's when we get into the genomic testing and the next generation sequencing that it can be more of a struggle. So I'm going to contradict myself and say, even though I'm a lover of precision medicine, and that's where I would like to see it go, I'm rooting for some of these trials to show an impact across all comers so we can give it to patients regardless of if we can get that molecular testing or not.
Yeah. Nicoletta, somebody in the chat asks, I have patients asking about genetic testing for a whole host of cancers and diseases. Thoughts?
Wow. So patient asking for, you said?
I think they mean like a whole host of diseases. It is sort of the new frontier in terms of not just a clinical diagnosis and scans or a pathologic diagnosis and biopsies, but molecular diagnostics. In Italy, how many patients are getting tumor genotype?
Well, this is completely different compared to the States. I think I know that this is really widespread in the United States. Unfortunately, in Europe in general and in Italy particularly, we are facing the problem of reimbursement. So this is not covered by the national health system. As you know, we have a national health system in Italy. So if it's not paid by the national system, then patients have to pay themselves, and they are not cheap, in fact.
No.
So what we try to do, we do have trials, even diagnostic trials. So to include patients in this trial where they can receive extensive genomic testing inside trials, so without having to pay for that. So that's the way we go usually, because I do believe in precision medicine as well. So I think, the beauty of this combination, of course, is the fact that it can work in, as you have seen, in all histologies, for instance, even in serous cancer or clear cell and endometrial. So you don't see any difference even across different histologies. Of course, there are possible more target therapy for some of these. For instance, for serous, I think, as you know, P50, besides the PARP inhibitor, which have been mentioned already, but also they have very often a P53 mutation, and this can be a target. There is, as you know, a drug which is a WEE1 inhibitors, which is inhibitors of the cell cycle checkpoint. which showed a very nice evidence of activity in serous cancer with more than 25% response rate. And now this is testing in a larger phase 2. So this can be seen as a more target approach to some of these patients, but of course not all. Then also there is all the hormonal treatment, which could be expanded in patients in the so-called low copy number, molecular subgroup. So I think there are several. Or HER2, we have data of activity of trastuzumab for serous tumor, as you know. So I think there are some possibility for more targeted therapy also in endometrial cancer, particularly now that the molecular classification is extensively used since the diagnosis, even for adjuvant treatment, as it was mentioned earlier. So I think there is a very great excitement right now for this disease, which was neglected until very recently, and now everybody is very interested in endometrial cancer.
Fabulous. Shannon, I think what Nicoletta is saying is that there is a burden, especially in America, and it's not just we have the privilege of molecular testing and we've arrived, to do the clinical trials that really demonstrate what is best for which patients, and that's an imperative. There's a lovely list here of targets. Do you have any biases in terms of the hot next topic?
I'm definitely a fan of WEE1, as Nicoletta already mentioned. I think that that we've already seen data from one of the agents, and there's another agent kind of coming down the pike that we hope will also have activity, and perhaps we'll see a difference in some of the adverse events. I think HER2 is exciting. I think the data around trastuzumab were interesting, especially with the addition of this to chemo. But I'm really excited about some of the agents that have been explored in breast cancer that target HER2, specifically the antibody drug conjugates. Those look really exciting, and I'm hopeful that we'll be able to potentially direct those towards our patient. And then we've been doing a lot with PARP combination strategies outside of the chemotherapy and the IO that we already discussed, but looking at combinations of PARP inhibitors with agents that target PI3 kinase or agents that target MEK, and have seen some really exciting data and are moving those types of combinations forward. So I think those are some of my favorites, although it's like asking me which of my kids I like the best. Like, I love all of them.
I especially love every single one. Good job. There's a great question in the chat. Any way to predict response to CPI or TKI testing ? And I do think this is fascinating, because one of the stories is that PD-L1 is not predictive of benefit in endometrial cancer, which is a real curiosity. Shannon, what are your thoughts?
Yeah, I mean, I think, outside of the microsatellite instability or the mismatch repair deficiency and proficiency, that I would note that we do in the States have a tumor agnostic indication for tumor mutational burden, which is something that can be obtained through some of the commercial testing opportunities that we have in the States. And so that is something that you can look at and potentially see outside of MSI. But other than that, I think there's a lot of great research going on, and I'm really hopeful that some of these big trials that are obtaining tissue will really help us tease out that amongst those patients with known mismatch repair deficiency, which are the ones that have the greatest benefit and which don't. And conversely, amongst those patients with microsatellite stability, and we've seen activity in a few of those patients, right? Like Nicoletta showed, there's a 13% response rate in some of, or 14% or whatever. There are patients that benefit that don't have that traditional MSI that still get benefit. So who are those patients, and what's going on with their tumor, and can we help identify those patients and get them the right strategy?
Yeah. So when we originally did the lenvatinib phase 2 in endometrial cancer, recurrent endometrial cancer, we were quite interested in soluble VEGF receptor and interleukin 8. but nothing's come out as a real predictor. As you say, it's a complicated biology. There are two topics I think that we really want to touch on before wrapping up. One of which is what dose we start at. Nicoletta, do you start everybody per protocol on 20, or do you use a 14 milligram starting dose in selected patients? Do you have a clinical system that draws on your medical experience?
You know, I heard a lot of people from the United States saying that they start, you know, not with 20, but they start already with maybe 14 or 18. Or I had a discussion also yesterday in at an advisory board with a lot of people, you know, treating also other pathologies or other tumors, and the point is that I think in the thyroid cancer, there were a clear evidence that you need a big dose at the beginning, like a booster, to achieve a shrinkage of the tumor. And if you achieve the shrinkage of the tumor at the beginning, then this will impact your progression-free survival. So that's why it is suggested, even though it's not endometrial cancer, of course, it's another cancer, but there is this evidence. So the recommendation, and I try to follow this, is to start with 20, because this is the label, the indication. But of course, we know that the majority of patients will have to decrease the dose. But it looks like this initial dose is important to reach initial shrinkage of the tumor. And this shrinkage can impact also the progression-free survival, so the subsequent outcome. So I tend to believe this, even though, you know, I don't have any direct experience. We know that 20 is too high for our patients. That's quite clear, because the majority have to reduce the dose. But it looks like this may be important.
Yeah, Shannon?
No, I would echo, you know, we start generally at 20, but if I have a patient that is maybe borderline on performance status, or, you know, not quite hardy, or maybe has a lot of issues with hypertension already, and I'm concerned about where we might be with adverse events, then we will start at a kind of a medium dose of about 14. But that we try to make it very patient oriented. Our institution did publish our data with the population that we did start at a lower dose and compared it to the high dose. And you know, obviously a single institution, small study, not practice changing, but provides a little bit of data to say, okay, this is okay. And because basically what we saw is that when we started, you know, for those patients that started at a lower dose, we still got excellent results and consistent results with what has been reported with the higher dose. And so certainly a little reassuring, but still needs to be better studied in larger studies.
Yeah. If you do start low, it's really hard to persuade patients to go up, because patients don't always feel great at the beginning starting on these new drugs. There's the sort of kicks in at 3 days, 2+ weeks to maximal effect sort of experience. So great thoughts. The second one is a really thorny issue. It's going to be our final sort of discussion issue. But I am really interested. Imagine our patient does great. First year rolls by, second year rolls by. There's granular abnormality in the right upper quadrant, but not much. They've had 2 or 3 immune-related toxicities, but like the lung cancer data, you know, most of those burn out by 6 months. So there's not as much late immune toxicity as we had feared when we first started using this agent. So you get to 2 years and slight abnormality on CAT scan, small volume peritoneal disease. Nicoletta, what do you do?
Well, I would not start immediately a new treatment, I think. I mean, if there is a clear progression, I you know, and particularly if the patient is not symptomatic, I think I will rely also on clinical evaluation besides the CT scan. Sometimes, you know, these are dangerous because you have to look at the patient, how she feels,
treat the patient.
And treat the patient. So not the CT scan or not So I will tend to wait a little bit. Yeah.
So you would keep people on treatment with a great response. Shannon, are you the same, indefinite treatment?
Yeah, I struggle with this too. I think, we obviously had that cut point, but if I've got a patient that's tolerating it well, we'll often continue past.
Yeah. There's a Matt Hellman's actually left Memorial recently, but in lung cancer, he's done some work on biopsying these patients. So that has that's become my evolving practice, that if I really think they're in a near CR, I will actually, so I have a patient coming close up to 2 years. We're going to laparoscope her, see what's there. If she has a pathologic CR, stop. She doesn't keep up that immune pressure to keep her tumor dormant. And I don't think it's too adverse an intervention to get biopsies or even laparoscopic evaluation.
Yeah, the only problem is the patient. Sometimes, they are completely scared, if they see one small nodule, they panic completely. Yeah. And the same is for ovarian cancer with the CA125, we are facing this every time. And so it's so difficult to convince them that it's not worth it.
Yeah. So we have been taking people off Cediranib after GY004 showed that for patients with BRCA mutations, you do just as well with olaparib single agent as you do with the combination. And so it is terrifying for our patients to stop these agents, which can be quite tough. By the third or fourth year of drugs like lenvatinib, you get a lot of skin problems, a lot of chronic diarrhea. They're arduous after years and years, and the patients are living terror and desperate for their next CA125 to drop 2 points or whatever. I really want to appreciate your academic excellence and your clinical wisdom. It's fabulous to have you, Nicoletta, and you, Shannon, with us today. To summarize, VEGF and immune checkpoint inhibitor combinations are the combinations, the reasonable combinations for the treatment of endometrial cancer based on their mechanisms of action. And lenvatinib and pembrolizumab are efficacious. They're the exciting new development. TKIs and CPIs present challenges, though, and I think the team effort, the sort of wisdom from these clinical resources so that patients get the maximum benefit, maximal efficacy, whilst minimizing safety risks and concerns. Early monitoring of adverse events, proactive management, these are all critical for getting the best for our patients and maintaining patients on therapy. We're wrapping up. Thank you, Nicoletta and Shannon, for a very interesting discussion. Let me close out this portion of the program with some SMART goals, which are smart, measurable, attainable, relevant, and timely. So our SMART goals are that clinicians should closely monitor, proactively manage emergent AEs, particularly in the first 2 months of treatment. Clinicians should consider consulting with a specialist early about symptoms that are resistant to management, and clinicians should continue monitoring women receiving pembrolizumab and lenvatinib combination for late appearing adverse events. Now, let's move on to the question and answer portion of this activity. If we have more questions and answers, let me just check. I think we've really been, it's the platform, my experience of the platform today for the first time has been excellent. And I'm going to just quickly look through and throw out questions. I'll alternate between the two of you. Here you go. Here's a European question, Nicoletta. Are there new guidelines from ESCO to address quality of life in these patients?
Well, we are just finishing our guidelines in endometrial cancer in ESMO, and of course we included this combination as a kind of standard of care as second-line treatment. Of course, the guidelines are quite synthetic, so I don't think we can spend a lot of time on quality of life. Even though the data on quality of life in this study are not so bad, actually. If you look at the quality of life, we did not see any clear detrimental effect. Maybe the instruments were not appropriate. I don't know. As you know, it's in any trial, it's very difficult to find a difference in quality of life. The only trials we showed an improvement in quality of life were the recent trial on cervical cancer, like the Keynote 826, because the control of disease was so important that you also improve the quality of life. But for the other trials, very difficult. So in this trial particularly, this was presented at ASCO by Ketalo Russo, and there was no detrimental effect on quality of life. So.
Cool. Shannon, do you fancy a last summary statement or a nightmarishly difficult question? Your choice.
Ooh, I'll go nightmarishly difficult.
Okay, you got the green door. Now this is the best question I have seen in this chat or any chat. So I'm going to combine two questions. Oh, I just lost the Q&A. I somehow clicked on it, but I can remember them. So one of them was the use of Mirena IUD in early stage patients. And the other question was, are there fertility impacts from checkpoint inhibitors? So imagine your young patient, low-grade endometrial cancer, you've treated her with an oral progestin, you're getting up to that 2-year portion. Would you, and it's clearly way out of the box, but do you see any future role for this sort of combination lenvatinib, pembrolizumab in that sort of patient?
Well, oh, sorry.
No, go ahead.
Was it for me? Okay. Well,
Yeah.
I have done a little bit of work with the IUD. I've run a couple of trials looking at that. So I am definitely a believer in utilizing progesterone therapy for early grade endometrial cancers. And I think the hope is that you can clear that disease entirely and to completely clear it so that you don't need something that I would consider a little bit more aggressive, like the combination of lenvatinib and pembrolizumab. I do think, though, I don't think that we have a lot of data around fertility, because I think we'd have to go to the thyroid data to look to see, or to the renal data to see if there have been patients that were still able, still fertility able, that got those agents. But to my knowledge, I don't think that they have an impact, or I can't think of a mechanistic reason they would. I think the issue for us is that for patients with endometrial cancer that are getting this combination, they generally, the uterus has already left the building, and so that fertility has been lost.
Yeah. So we do not want to start on a rare thing, but it is amazing how good the placenta is as keeping stuff out from the baby. But to summarize, just to restate that pembrolizumab and lenvatinib is just an amazing new FDA-approved combination for patients with advanced endometrial cancer that is not MSI high or deficient mismatch repair. They've had disease progression on prior systemic therapies, and they're not candidates for surgery or radiation. I want to thank you again for being such great experts, and I want to thank CME Outfitters for a fabulous platform that allows us to get the state-of-the-art information at our fingertips. Thank you.